Great. It's great to be here to present on behalf of my co-authors and the search collaboration. So we all know that HIV and tuberculosis are linked epidemics, and the benefit of treating HIV on reducing the risk of active TB disease is well established both on the individual and the community level. For example, our group published findings from the SEARCH intervention, which is a universal HIV test and treat strategy with patient-centered streamlined care, and showed that this intervention reduced the incidence of active TB disease among people with HIV by 59%. But what is not known is how much the intervention worked by reduction in reactivation of latent infection, or was there an effect on reducing person-to-person spread of tuberculosis? And few public health interventions in HIV and high TB burden settings have demonstrated an effect on interrupting TB transmission on a community-wide level, a population level. So it was with these questions in mind that we sought to assess whether the SEARCH intervention reduced TB transmission on a population level. So let me talk about our primary outcome, which was 1-year cumulative incidence of TB infection. Why did we look at TB infection? Well, it in of itself is an important outcome. We know a large reservoir of latent TB infection drives TB disease and death. And then incident TB infection is a marker of recent TB acquisition and can mark community-wide transmission. So let me tell you about the SEARCH trial. Phase 1 of the SEARCH trial was a 32 community cluster randomized trial in rural Kenya and Uganda. Our hypothesis was that this strategy would reduce new HIV infections and improve community health compared to a country guideline approach. Here's a little bit about the intervention component. So the intervention component in the intervention communities, at baseline and annually, we did multi-disease health fairs. So people came, they did HIV testing, non-communicable disease screening like diabetes testing. And for those who didn't come to the health fairs, they had home-based testing. We also had a streamlined, patient-centered, co-located HIV and NCD care delivery strategy. And then ART eligibility was all people with HIV. In the control communities, which we had an active control, people received baseline multi-disease health fairs, and then HIV and NCD care was delivered per country guidelines, and ART eligibility was per country guidelines at that time. The findings of SEARCH have been widely presented elsewhere, but just to summarize, the intervention increased many aspects of community health, including increasing population HIV viral suppression, decreasing HIV-associated mortality and tuberculosis, and increasing household economic and education indicators. So within SEARCH, phase 1, we, in 9 communities in eastern Uganda, we nested a TB infection study. This was a household study, and all persons in the randomly sampled households, which were enriched with, for households with people with HIV, all residents over 5 years of age were eligible. And we placed a tuberculin skin test in eligible participants at baseline, and those who were negative, who had a negative TST, we went back in a year and placed another tuberculin skin test. We also had a TB-specific questionnaire, and we were able to assess demographics and HIV status from the SEARCH study, and of note had HIV status in over 90% of residents. So here's our outcome again, 1-year cumulative incidence of TB infection, which we defined as a conversion from a negative TST at baseline to a positive one at 1-year follow-up. The analytic population included children and adults over the age of 5 in our 9 communities. And we compared between randomized arms with targeted maximum likelihood estimation, accounting for sampling, measurement of TB status, and clustering. We had a pre-specified analysis of looking at age categories, and let me walk you through the results. So here's our study flow diagram. So remember, we're looking at 9 communities in this household sample. Over 8,400 individuals were registered to these 1,400 households. And we were able to administer TSTs in over 4,800 of those individuals, so 58%. 22% of people were TST positive at baseline, And then over 3,800 remained in the TST negative cohort. We then went back a year later and were able to place TSTs in 78% of those individuals. This is just a snapshot of the demographics at baseline in the intervention and control communities, just to highlight a few of the demographic features. A large proportion of children under the age between 5 and 11. HIV in intervention was 10%, and people with HIV in the control was around 13%, and over 90% of people in both arms had BCG vaccination evidence via SCAR or vaccination record. So here's what we found. In the search intervention reduced TB infection by 27%, so at an adjusted relative risk of 0.73. And you can see the cumulative incidence measures here, 16% versus 22%. Here's our pre-specified subgroup analysis, and you can see a larger effect in the 5 to 11-year-old age group, or pronounced effect, 0.71. So here's a little bit about our hypothesis of why we saw a reduction. And the search intervention is a multi-component intervention. We can't really disentangle a lot of the pieces, but this is our hypothesis. One, the intervention could decrease susceptibility to developing TB disease through increased HIV viral suppression, thereby having fewer people with active TB disease in the community. Second, a probable impact on infectiousness. We saw increased engagement in care in the intervention communities, and perhaps this increased early identification of TB treatment as well as treatment initiation, thereby decreasing the time in which someone who had TB is infectious. And then likely an impact on social determinants of TB, which then in turn decrease susceptibility. So let me touch on limitations. I think firstly, the outcome measurement. There's no gold standard for measuring TB infection. TB infection can be messy, and with tuberculin skin tests, you can have false positives due to BCG vaccination, as well as boosting with serial tuberculin skin tests. I think the boosting was likely higher in the intervention arm due to increasing virologic suppression, and thus likely underestimated the effect. And then secondly, differential participation of measurement. You had to be home for a tuberculin skin test, which we adjusted for in our pre-specified statistical analysis plan. So just to conclude, a universal HIV test and treat intervention reduced incident TB infection, which is a marker of population-level TB transmission. And I think the take-home point is that investments in community-level HIV interventions can have direct impacts both on HIV and broader population-level benefits, including reductions in TB infections. So with that, I wanted to acknowledge co-authors, the search team, and PIs and funders. Thanks.